Good evening, everyone. Thank you all for taking time this evening. We're really excited. My name is Dr. Alex Pavidapha. I'm an interventional radiologist, and I'm joined tonight with Dr. Marcus Jones. We're going to be discussing a new embolization procedure which helps address a specific type of erectile dysfunction called venous leak. So, without further ado, we have a slide deck or a talk that we want to give to you guys, and then towards the end. We have common questions and with answers, and then also there's a chat function here on Zoom that I will be monitoring throughout the um, length of the talk, and I'll try to address specific questions during the talk, and any questions that we feel can kind of apply to a more broader audience, we'll try to address towards the end of the talk. So go ahead, Marcus.
All right, you guys can see my slides here.
Yes, we can.
All right, thank you for that introduction. All right, thanks for everyone for joining us this evening for our webinar over erectile dysfunction with venous leak embolization as a treatment. We did our intros here. All right, so let's dive into this and understanding erectile dysfunction. So let's define this. Erectile dysfunction is difficulty getting and keeping an erection firm enough for sexual activity. This affects 30 million plus men in the US. We know 30% of ED patients really don't respond to oral medications. Now, there are various causes of erectile dysfunction. And briefly, in terms of we want to get talk briefly about physiology, arteries are going to bring blood flow to the penis, and veins are going to help drain the penis. So, in terms of talking about cardiovascular disease and hypertension, well, this may play a role in bringing blood flow to the penis. Are there narrowings or blockages that will decrease blood flow into the penis, causing erectile dysfunction? To talk about diabetes, we know long-term high blood sugars, damage blood vessels and nerves that control sexual arousal, causing ED. Having low testosterone, this is essentially lowering your sexual drive, causing ED. What about psychological or anxiety-related factors causing ED? And then last, venous leak, and that's what we will tackle tonight. So, in a normal setting, during arousal, veins in the penis are going to compress. It's trapping blood to maintain erection for sexual activity. In the setting of venous leak, these veins will now fail to close, and now blood is allowed to escape too quickly, and the erection cannot be sustained for sexual activity. Now, there's various severities of how this will um, play out. Some patients may say, "All right, I can achieve erection, but I can't maintain it for sexual activity, or it's not rigid enough for that." What about patients who were on oral medications and maybe they once worked, or now they're just not as potent as they once were? What about patients who need constant stimulation to maintain their erection? All of these things can play a can play a role and may have some severity and maybe some things that you guys have that may be similar to yourselves. So what we know, this is a chronic structural condition, but it is treatable. And common causes of venous leak, just beyond, say, normal aging or connective tissue changes, patients may have a history of pelvic trauma or maybe some post-surgical changes as a cause to their venous leak. But this can still be treated with venous leak embolization. So let's talk about the procedure and what this looks like. So the day of the procedure, this is an office-based procedure. We have you lie on your back on the exam table. We still, at this point, we do need to have or achieve an erection for the procedure and for access and to be able to diagnose and do the venogram for our procedure. So what does that entail? Well, we need to inject a prostadyl or trimix, meaning you patients may already be doing these injections. So we'll do the same thing at the time of the procedure. We also will require to numb the access site. So before you start thinking, wait, I just spoke about two injections to the penis. Let's let's pause here and say, this is a very tiny needle. The skin at the site is thin, so it really won't be as traumatic. as you might think. But after getting access, we're able to get a small catheter at that same site. Routinely, there's really not much pain throughout this procedure. No general anesthesia is required. There are no surgical incisions. So upon placing the contrast dye, we can now, the small catheter, we can now inject contrast dye. Now this is being visualized under real-time X-ray or fluoroscopy. We're able to assess the many outflow veins in the pelvis that we'll soon see images of, be able to diagnose, and then therefore treat thereafter. We're treating with a medical grade sclerosant. So this will allow us to capture many of the outflow veins that we'll see. Sometimes there are tiny coils that have to be placed for us during the treatment process to continue with the sclerosant, and we'll show you some images of what that looks like. Upon completion, we remove the catheter. There are no stitches. We will monitor you before we let you ambulate and go home. So let's talk about access. So the deep dorsal vein. Here are some grayscale images, and one's going to be a little cine, little movie of what we're looking at under ultrasound. The top small dot is our superficial dorsal vein, and the one below it is our deep dorsal vein. In our movie, we do see how this courses into the pelvis, and this is the access that we want to achieve. Our illustration here on screen left is almost like a transverse section. Say we cut the penis in half. What we just saw was that smaller dot was the superficial dorsal vein, and beneath it is the deep dorsal vein, and that allows us to get access for treatment. Here on the right, we see a live image and video of what this looks like on an actual patient. We already have access to the base of the penis, and now we're inserting a small wire through that access, which then allows us now to move on to X-ray or fluoroscopy. And this is what this looks like. We have our needle access with a wire in, and both of these images are showing the same. We have needle access, we have a wire to help stabilize our access. Once that is present, we are then able to place a small catheter. Now, all of these images are just showing you different projections of what that looks like. So we are going to inject contrast, as that darkening is the contrast filling the many outflow veins from the penis. Now, just think, so right now the patient, we have an erection. We shouldn't have so much outflow during the time because we want to keep that blood in the penis. So this is another projection of what that looks like. And it's important to note that in terms of treating venous leak, and there is a surgical approach where there's surgical ligation of these, and we can see how tedious and how invasive potentially trying to ligate all of these mini outflow tracts, and wonder why surgical ligation may not have the success or long-term success that maybe a liquid sclerosant can do. So after we did our venogram, we have our diagnosis. Now it's time to treat with that sclerosant. We monitor the flow, we know what it looks like, and now we're slowly injecting that sclerosant. And the goal here is to have that darkening of the sclerosant mixed with contrast to have more of stasis or be stagnant flow. So now we're having decrease in the outflow veins during the time of erection. Now we have another case here. We've already gotten access. Now we're ready to do that first venogram or injection of contrast. Well, here we see some brisk flow going towards screen right there to a larger vein. Well, this larger vein is actually going to the leg, and they can go more centrally to the body. In this setting, we want to try to eliminate that brisk flow because we don't want that liquid sclerosant going to where we don't want to. So we're able to use smaller catheters and wires to be able to get into that vessel, be able to place a small coil, which is now going to seize flow within that vessel, so then we can safely give the sclerosant behind that. And as we see this on the second movie, and that is the case, and we can be able to still manage and give that sclerosant while monitoring that lower one. So what should you guys know as patients? Well, the procedure that I just showed you should take about 1 to 2 hours. Clinical success rate is about 68 to 70%. Now, this is in the short term, initially 6 months, 12 months. In our experience, in select patients, we're seeing greater than 90 percentile up to now beyond 12-month time period. Now, we have data from 2000 all the way to 2025, and we have limited results from beyond a 24-month period, and we still have more data to collect to be able to report data beyond that time frame. As I mentioned, this is a office-based procedure, so it requires no hospital stays, no general anesthesia, and we're walking out the same day. So in terms of looking at candidacy, we really want to capture patients in which they failed the treatment algorithm and we can intervene before surgical approach. So in terms of working out, we have patients get a penile Doppler ultrasound. During this ultrasound, we still need to have an erection, so you'll get that similar injection in the penile tissue. Some patients that are already on that, whether that be Trimix or Prostadil, so that we can get accurate diagnosis of one, arterial inflow to the penis, and then two, what is the velocities leaving the penis during erection. And that will let us know what direction to go. Some patients who are already on oral medications like Viagra, Cialis, and maybe they've worked for you well previously, but now you feel like lost some of their potency. That's time for maybe to seek other treatment options like Venous Sleep. We really want patients to um, have, I guess, be in general good health. Having no serious heart or vascular conditions or other comorbidities is important so we can have a safe procedure for you. Um, in terms of also creating the correct patient for venous leak embolization, we want to be able to target patients who are mainly have venous leak and not have a combination of maybe they have arterial inflow. So during the penile Doppler ultrasound, we want to make sure that there's adequate blood flow going to the penis so we can really focus on the venous leak aspect. Realistic expectations. We touched on the 68% success rate. We're seeing 90 on select patients who really have a venous leak only versus other arterial or psychogenic. And we know that there's going to be different severities. Some patients will also have better results early on than patients who may have to wait a longer 3 to 6 month time frame. Being a non-smoker or being willing to quit smoking is important. Nicotine, toxic chemicals, and cigarettes are narrowing arteries, damaging blood vessel walls, and prevent physical relaxation. That's an action needed for erections. So it's important to be able to eliminate smoking. Your diagnostic workup, we touched on penile Doppler ultrasound. We're showing two still images of what this looks like. We're assessing the velocities of blood flowing in, but also blood flowing out, and meeting certain criteria for your diagnosis. Your workup will also entail lab work. We want to be checking your testosterone levels, your blood glucose levels, cholesterol, all the things that can affect your vascular health. We will monitor that. Looking at nocturnal tumescence test, not every patient will need this. This is a home test, monitors natural nighttime erections, and we really want to know if your erectile dysfunction is physical or emotional in origin. MRI of the pelvis, not everyone will need this. We want to assess here if there's a prior structural or anatomy issue we need to address. Same thing with CT angiography. What if you had concern for arterial inflow, and we want to assess that, or any other abnormality from an anatomic standpoint that we want to address? These are imaging studies that can be ordered on a need basis. What about your recovery? Well, the day of the procedure, we talked about you going home the same day. You may have mild soreness at the site. Um, you will need a ride. We will be using moderate sedation for the procedure. So there will be about 24-hour period or so where aren't allowing you to drive. During the first week, essentially are telling you no heavy lifting, strenuous activity, or exercise. Beyond that first week, into the week two, we can now say, all right, let's get back to sexual activity. We really want to know at this point in time how things are going. Some patients will see more dramatic results early on. Some patients may take 3 to 6 months to fully assess where you are, and before we talk about um, other recommendations or if there's other treatment regimens that need to happen. So expectations, outcomes, patient counseling, 68%, 70% receive 90% in select patients with sole venous leak. After the procedure, many men are able to regain natural erections over time. Again, some will have to give this about 3 to 6 months to really fully assess and see and to be able to recommend other treatment options if need be. Now, half of the men are we seeing are able to achieve erections and are being able to get rid of their medications. But we are seeing that patients who want to stay on a low dose medication like Cialis will help support and enhance the post venous leak embolization results. And we're seeing that, especially patients who are able to maintain those medications without having any side effects. Again, results will vary. The procedure was really focusing on venous leak. If there's arterial, psychogenic, or any other players that are the cause of erectile dysfunction, we want to seek separate treatment for those so that you can get your best results in terms of treating your erectile dysfunction. So other treatment options, oral medications. Many of you patients are already on oral medications, Viagra, Cialis. Again, what if these medications once worked for you, now not as potent you feel, you're having to increase your dose. We talked about some men continuing, and especially patients who aren't having much side effects and who can tolerate those medications, staying on a low dose or taking them as a boost. Um, Penile injections, many of you are also on a prostadil or trimix, small injection within penile tissue. These are highly effective, but still can wane and not be as effective over time. And if patients are needing those or not quite, or need more information on that, your care team can be happy to discuss those with you. Now, vacuum erection devices, these are essentially using negative pressure, gentle suction to draw blood into the penis and create an erection. These can also be used after the procedure as an additional tool. Again, this is an aid and not a permanent solution for venous leak on its own. Lifestyle and insurance, another important factors here. Having a healthy weight, so extra body weight will increase pressure in your veins and disrupt hormones. So we know that even a modest weight loss can be meaningful in improving erectile dysfunction. Smoking, again, not having to have the nicotine and toxic chemicals, maintaining the vascular components for erection is important. So quitting is one of the most important things that you can do. Having uh, control over poorly controlled blood sugars are important. And then exercise, regular cardio exercise, just even simply walking, we know improves blood flow. Naturally, you're going to get some testosterone boost and help support your long-term sexual health. In terms of talking to you about insurance coverage, we're seeing so far that insurance carriers are covering this. This is a vascular abnormality. Prior authorization is needed, but there are cases where there are issues with coverage, just like with oral erectile dysfunction medications. Many insurance carriers do not cover this. Now, and based on what carrier that you have And if there is, for instance, no coverage, we can still talk to you about what self-pay look like and create plans that can make venous leg embolization a possibility for you. So we have some frequently common questions here. Alex, I don't know if there's been any questions in the chat, but we can go over some of these and address any of your guys' questions that maybe weren't covered.
Yeah, so I think yeah, great job, Dr. Jones. I think one thing that I'd like to reiterate too is that like Dr. Jones said, venous leak is a known entity for erectile dysfunction. Treatment options have been around for decades. The 68% that he kind of quoted as kind of the historical literature, our success within our group or our platform, which we didn't really talk much about us as IR centers, but we're probably the leaders in embolizations in the country, performing tens of thousands of high-end complex embolizations a year. Our experience where he talked about upwards of 90% clinical success. I think a lot of that is attributed to exactly what you described. It's appropriate patient selection, meaning the patient had already gone for a penile Doppler, and it shows that he has venous leak. But then also innovation and evolution in techniques that we administer, like you mentioned. We use basically like this paste material with the sclerosant, which helps irritate it. So rather than, like you were alluding to, just kind of cutting it open and tying off whatever vein you see, we basically can cheat and we can use live X-ray or fluoroscopy, characterize that leak, and then use that medicine to kind of block it off. And you walk home the same day. This is all done through a pinhole. So it's a really exciting um, time to have this treatment option. And honestly, it falls between, there's a big gap, right? So there's failed medical therapy. You can potentially try the injections. And then you can do the vacuum device. But then the next step would be implants. And once you have an implant, you can't really get an erection on your own. So this really bridges that gap. It doesn't close any doors, obviously, but it's worked really well. So yeah, I just want to kind of reiterate that. I know you already mentioned all those points, but just to kind of reiterate.
Okay, those are
Um,
good.
so these are common questions that we get asked, and I think you covered pretty much most of them throughout the talk. Um, but uh, you asked, well, how long does the procedure take? Um, Dr. Jones, what would you say to that? I think sorry, I missed out the previous slide, but
No,
you
yeah,
asked
it's
that.
1 to 2 hours. Normally it's going to be less than that 2 hour mark, but an average probably be 1 hour.
Yeah. We have a question in the chat. Can this procedure be done with patients with Peyronie's disease, mild or not so mild? It can. Now, Peyronie's disease in itself can have issues with erections, but it can be done. And I've performed it on patients with Peyronie's disease who have done tremendously well. So that is not a contraindication. Um, how will I know if I qualify for this procedure? What do you think about that,
So we
Marcus?
still have to follow up with our urology colleagues, and we still want to, as we talked about candidacy, having the penile Doppler ultrasound. Let's find out if venous leak is the source of your erectile dysfunction rather than is it hormonal, psychological. We got to rule out other factors, and that will dictate your candidacy and us proceeding with venous leak embolization. But beyond, say, beyond labs, it's following up with our urologic colleagues, having that penile Doppler ultrasound. Let's talk about if venous leak is the main source for erectile dysfunction, and we then go from there.
Okay. And this one you kind of addressed as well, but will I be able to have natural erections again?
Yes, patients post venous leak embolization are having natural erections. We touched on their improvement. We touched on half of patients are actually being able to get off medications, and then there's some who still want to maintain a low dose Cialis to help boost or provide support post venous leak embolization. But yes, patients are naturally having return of erections.
Yeah, and I think that's been the experience that I think most of my patients would say some of them will be able to get erections on their own, but they actually the quality of erection that they have
Mm,
after the procedure with the medications is really good, and a lot of them will continue taking them, but some of them will stop if they have side effects like headache, congestion, or stuffy nose, things like that. Then they'll stop, and they'll still be able to get an erection. Um, you talked about insurance coverage. Um, I think on the previous, I think it was was it the previous page? There was a couple more questions. You talked about recovery. We talked about how likely it is to work. Um, you talk about no overnight stay. I think
yep.
one
Hmm.
one 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 thing is that we didn't mention is that so risks with the procedure. I think this is
Yeah.
obviously a very low risk procedure. Really the biggest risk is infection. You take something from outside the body, inside the body, there's risk of infection. We sterile technique, give antibiotics, so that risk is very small, but it's never going to be zero. Um, Potentially bleeding or bruising at the access site, which is also usually just minimal, and a little bit of soreness. But the one thing I do mention is, and I've seen this a couple times where it's a good predictor, but we give that medicine, that trimix medicine, to help stimulate an erection. And usually most men are there because they have venous leak, so the erection isn't a very strong or firm erection. But I've seen after we've done the treatment, the patient has a prolonged, really firm erection, which is called a priapism. So there are times where we will inject a medicine to help reverse that.
Mhm.
But that's why we keep you to monitor afterwards. So that can, in theory, happen. Um, so that's one. Those are a few of the things that I mentioned to patients. So
And that
um,
medicine that he's talking about is it is temporary. And so once it's just there to help alleviate or cause detumescence or to have the erection de go down before we let you go home.
you got it. Here's some questions in the chat. I have not had a full erection in 5 years. Do I qualify? I would encourage. So, as Dr. Jones kind of mentioned in the talk, there's multiple causes or etiologies for erectile dysfunction. You very well may qualify, but I would encourage you to see your urologist. And really, the true way to assess that would be that penile Doppler or that ultrasound that he mentioned. I've been told I have a leak because I can't get an erection laying down, only erection standing up. So that is a very clinical, that's a common clinical scenario. Is that common with leak? Yes, that's
Yeah.
absolutely very common with leak.
Mhm.
Um, if you're on the top, oftentimes you can get an erection much better, but when you lay down or you're on the bottom, you can't maintain that erection. That's a common presentation or reported symptom with venous leak. Answer that, these are great questions. You talked about the lifestyle changes, recovery. You also mentioned, yeah, I think one thing that I mentioned to patients in as far as recovery goes, and you had that. Um, uh, in the talk was that the first week we kind of want you to take it easy, and then after that first week, we actually encourage you to either self-stimulate or engage in sexual activity to see where you're at. Now,
Yeah.
that being said, if you don't see a full response in that second week, that's not to say, oh, it didn't work or it's a
Yeah.
failure. It can take up to 3 months, 3 to 6 months before you see the full improvement. I will say too, um, it can be, I'd say 90% of the time, or maybe 90 plus percent of the time, a single treatment is enough. There are occasions where, and I think we've discussed this too, Marcus, but where we get that access in that dorsal vein, just like how he showed in that video. But sometimes the way the leak is, it's so brisk that you may want to get another access point and treat
Yeah.
from somewhere else. So there are occasions where we will bring you back. It's going to be less than 10%. But vast majority of times, it's all addressed in one single treatment. Um,
To piggyback on that also, so our main axis is the antegrade, so the base of the penis, but say there's an issue with the access or any other vascular abnormality, going from a retrograde approach, meaning access in the femoral vein in the groin, can also be a pathway down to the pelvic venous plexus too. So that's another option, but just the antegrade is the initial approach.
I got a question here in the chat. If erection is non-existent, will shots work? The only way you know is if you try. And the urologists that I work with, that's kind of been their approach. But it will not hurt to get that ultrasound done, that penile Doppler. I think we pretty much
Yeah.
covered all of these. Um, Anything else you'd like to add?
No, I think I'm glad everyone who joined in tonight and taking the time to join us for tonight's webinar. Feel free for sure to reach out to us at Irish Standards here in St. Louis. Our actually colleagues or urology colleagues. If you're inquiring about this later on, if you have additional questions, you want to talk about workup, I'd be happy to either help advocate to get you to the right uh, diagnosis to see if we can help with venous leak embolization.
Yeah, and also just want to thank everyone for taking the time out of their evening. Um, you will be receiving an email afterwards, and those who registered and didn't come on, obviously you'll get an email in this recording of this presentation as well. But really appreciate everyone's time. Appreciate your time, Dr. Jones, and thank you. Have a good
Thanks,
night.
thanks for joining us.